Ray has joined. Dr. Kurzrock is here. Welcome, Dr. Kurzrock. And with that, I thank Dr. Raja, Dr. Christophenelli, and Dr. Senthil Rajappa, all the panelists for the wonderful discussions that we just had. We move over to the next segment, and to welcome Dr. Kurzrock, I bring in Mani again. Mani, please go ahead and welcome Dr. Kurzrock, and then I'll formally introduce.
Thanks, Avanti. Again, thanks the previous panelist. That's a spectacular. I'm at MD Anderson. I see MTB email coming out every day, every other day. But I always kind of used to think that I never participated in one. So today it's an educational and at the same time highly informative. This is the way I feel every patient should be treated. Getting an input from various people and getting a perspective, and then going on and treating the patient. So thank you for that wonderful discussion, Dr. Raja, and all the panelists, and Massimo for your guidance and advice, and thank you all. So one other thing we are also thinking, just before I move on, just want to say that our dream, the reason why we are making this global, the Iylon operation, our interest, is to make sure that we gather research information as well, so that we all can work together on the research side, in addition to just being on the helping the patients. We want to help patients, and we want to learn, and we want to help better. So okay, thank you. And now it gives me great pleasure to welcome our next speaker. I'm just going to give just to say a few things about how I met Ray, and then what a great person she is. When we approached Ray a while ago, I think more than a year ago now, we were pleasantly surprised. We thought that Ray is super busy with so many other commitments, so therefore we thought she might say, "No, sorry, I'm busy, I cannot." But then she said, "Let's have a meeting," and then we met and we discussed. We walked the program. She said, I am going to schedule a meeting. So instead of us asking her, can we have a meeting, and she scheduled it herself on every couple of months to meet with us to see how it is going. So when we asked, why are you so passionate about it? And she said, the patients, she get requests from patients from all around the globe, but her hands are tied. She cannot go out and help a patient beyond what she can do as an academic scientist. So this Iylon could serve as a platform to help patients beyond her hospital, beyond the state, in the country. So thank you, Ray. And for those of you who may not know much about Ray, she was at MD Anderson when I joined MD Anderson, and she set up a massive phase 1 tumor agnostic program where the patients can be treated based on their genomic alteration independent of the cancer type. Right? A breast cancer patient could be treated with a medicine drug approved for a prostate cancer as long as that mutation is present. So that was quite a powerful kind of setup, and she is also passionate about bringing the precision medicine in particular to the most parts of the world. So thank you, Ray, for all your advice, and we are really fortunate to have you as an advisor. With that, I pass the mic back to Seventy. Thank you.
Thank you. So Ray, I'm just going to say 2 sentences in addition to what Mani just said. So Dr. Kurzrock is a professor of medicine at Moores Cancer Center, University of California, San Diego in USA. She's Associate Director of Clinical Sciences and Director of Personalized Cancer Therapy at the center. And I think Ray's work has been revolutionary and transformative in precision oncology. Each one of us that follow precision worship her methodologies and truly are a huge fan of the work that she does. Not only that, we have, in just by following her, been handheld into managing our patients. And right after Ray's talk, we have a moderation by Dr. Nirmal Rao. And you will see how each one of us, and that's one of the reasons to bring him into moderating that case. It's like Eklavya. I'm not sure if you've heard the story of Eklavya. You know, we are Eklavyas. We are away from her, but we watch her work and we follow her. With that, I bring Ray to all of you with her talk, and this will be followed by a short introduction of Iylon by Dr. Padmaja Ganpati, and then we'll move over to the Molecular Tumor Board by Dr. Nirmal Rao. Ray, please go ahead. The stage is yours.
So thank you so much for that wonderful introduction. So again, I really loved watching that Molecular Tumor Board. And I also really enjoyed some of the seeing some people that I hadn't seen for a long time, like Massimo Cristofanelli, who was at MD Anderson. So these are my disclosures. And this is my experience that really has spoken to where my thinking is regarding precision medicine. And so the initial experience was from MD Anderson Cancer Center, where I founded, built and chaired a very large clinical trials department, what really became probably one of the largest in the world. As was said before, it was focused on phase 1 trials, but we began to get a glimpse with early technology, first generation technology, where we did PCR on a few genes, the power to match patients with drugs that we'd never seen before. We were seeing responses in patients with end-stage disease that we hadn't seen before. I then moved to UCSD, where I had many roles, and the one that I was really passionate about was the Center for Personalized Cancer Therapy and the Precision Medicine program. And I'm going to talk about some of the things that we did in that program and have published, because I think that they really bring in the next generation of precision medicine. Exactly what was talked about in the Molecular Tumor Board, individualizing therapy for every single patient. And as was mentioned, I really have a passion for bringing this globally, and I've recently moved to be Chief Medical Officer for the WIN Consortium for Personalized Cancer Therapy, whose mission is to globalize precision medicine. And this is a nonprofit consortium involved in multiple places in the country. So these are my take-home points. The whole point of precision medicine is actually very simple. We're making it very difficult, but it's pretty simple. And I think it's because it's a change. The whole point is to understand what is wrong in every individual's tumor, not to guess, as we've had to do in the past, based on population statistics. But we now have technology where we can interrogate each person's tumor and know what's wrong with their tumor. And I don't care what's wrong with 1,000 other tumors. I just care about the patient that is sitting in front of me. And it turns out that this is really important, because every metastatic tumor is unique and it's complicated. So I've lived the last couple of decades in Houston and in San Diego, but I actually grew up in Canada. And so I know a little bit about snowflakes. And tumors, metastatic tumors, are like malignant snowflakes. The characteristics of snowflakes is that each one of them is unique and each one of them is very complicated. And that's exactly what metastatic tumors are like. And because of this, metastatic disease, I believe, requires customized, individualized combination treatments, not random agents based on population statistics and not single agents for the most part. Next point, the pillars of precision medicine are genomics and immunotherapy, and people think of them separately, but we think they're married to each other. And while targeted genomic therapy may be best suited for simple tumors, or the simpler the better, interestingly enough, immunotherapy is best suited for the most messed up, most genomically complex tumors. So this was alluded to before, but what has happened with genomics is just breathtaking. I remember in the 1990s, if you said the human genome would be sequenced, they said fake news, science fiction. But you know what? Because there were people that believed this could be done, by 2003, the first human genome had been sequenced, but it took 13 years. Today, we sequence a genome same day. The cost of the sequence was $2.7 billion for one patient. By the time I was running the phase 1 department at MD Anderson, it had dropped to 100 million per patient. That was a steep drop, but still very hard for my obviously research grants or for insurance. Today, we can do clinical grade sequencing for $1,000. This is clearly available for patients. So I believe that this is breathtaking progress, unparalleled in human history. But it turns out that this progress, while we're so excited about it, has brought out problems. And the problem is that the data is complicated. And what the science is revealing is that we need to change what we're doing. And it turns out that changing what we're doing is almost as hard as understanding genomics, because people are used to doing, I'm used to doing what I've always done. But we need to listen to what the genomics is telling us, what these techniques are telling us. But we've been evolving quickly, and there's an evolution of clinical trial design that has happened. And this is basically what has happened. We initially thought, this is an example, that lung cancer was one disease. When we thought it was one disease, our therapies worked really poorly because it wasn't one disease. Well, so now we understand that lung cancer has multiple different subsets, EGFR, BRAF, ALK, HER2, whatever. But that's not the end of the story. That's just the beginning. Now it turns out that you can have all sorts of different cancers, lung cancer, breast cancer, colon cancer, and they can have the same alteration. And it also turns out that if they have the same alteration, more often than not, you can target them with the same drug. And then that means that we have a whole new set of trials. Whereas I grew up with randomized controlled trials as the gold standard. We randomized unselected patients. We needed the statistician to see the difference between groups because the group differences were often small. And only a small number of patients responded. Now we have a new model where we can very highly select the patients and get very high response rates. And the way we select them is with understanding the molecular aberration and having drugs that have been developed to really impact that molecular aberration. So this has given birth to the beginning of a new era. And this is tissue agnostic approvals driven by genomics. And so the first of these was pembrolizumab, an anti-PD-1 for solid tumors based on mismatch repair gene defects, and had a high response rate, about 45%. This was May 23rd, 2017. Very important date because it broke the glass. And there were three things that happened that were really, really important. The first two, I think most people know about by now. The third, I don't think most people know about, but it's maybe the most important. So there was a tissue agnostic approval. It was for all solid tumors. Doesn't matter if you have colon, breast, lung, whatever. And it was an approval of immunotherapy based on a genomic marker. And the third part of the approval, which is maybe the most important, but most people don't realize, is it was approval partially based on real world data. So the FDA opened the door to real world data. Remember, we have computerized records on millions of patients now. We never had that before. This is really a tremendous potential to get faster approvals. But this isn't the end of the story. This was just the beginning of the story. So then we have larotrectinib, which is an NTRK inhibitor for NTRK fusion adult and pediatric solid tumors in 2018, entrectinib, again, tissue agnostic approval in 2019, and pembrolizumab for high tumor mutational burden, again, in 2020. So repeatedly, multiple approvals. And for drugs like larotrectinib and entrectinib, this speaks to the small studies that are very focused. These are studies of about 60 patients, but the response rates are about 75%. So very striking responses. So I want to now talk about genomics and immunotherapy marriage, because the genomics and immunotherapy to me are the pillars of precision medicine. People think that they're separate, but they're actually a couple and they're married to each other. And what do I mean by that? Well, as an example, the immune system responds to the mutanome and to mismatch repair gene defects. PD-L1 amplifications are predictors for immunotherapy response. And then furthermore, in my view, and I know this is controversial, but this is my view and my experience, the higher the mutational burden, to me, this is the single most important predictor. The higher, the more mutated the tumor, those terrible tumors that we thought would never be treatable. But now we know that the more mutated the tumor, the better the response rate is to immunotherapy. So talking a little bit about what we've done, we started a rare tumor clinic, which was a precision medicine clinic. And in this clinic, rare tumors are about 25, they're individually rare, but they're about 25% of the tumor burden, and they are a big unmet need. And we initiated a molecular tumor board. We've done molecular profiling, a lot of experience. And this is clinical grade, about 21,000 patients. We brought together all different types of physician specialties along with our computer scientists and our basic scientists. And we published the first edition from this tumor board on 715 patients in Nature Communications. And then I want to give you some examples of things that we've done. So this is a patient of mine with metastatic basal cell carcinoma, a 55-year-old man, failed multiple therapies. These patients have patch 1 alterations. The FDA approved therapies are vismodegib and sunitinib. The patient completely failed this, was on the way to hospice, had liver, bone, and brain metastases. And the question is, what do we do with this patient? Lots of different possibilities, maybe sent to hospice is one. We did comprehensive genomic profiling. And this patient, this is the reason that he failed the patch 1 inhibitor. What you can see is that he has multiple other alterations. So one gene targeting just not going to work. And we treated the patient in October 2015. This was before high mutational burden was known. He had very high mutational burden. He had PD-L1 amplification. This is his tumor before therapy, large liver tumor after therapy. And he has an ongoing complete response now at 5.5 years. So this is what has made people really excited about immunotherapy. But I want to tell you that it's not all good. And even though we're excited about immunotherapy, clearly there's problems with it. And this is an example of some of the problems we've seen. This is a breast cancer patient that had hyperprogression or accelerated progression. This is her response response. This is her tumor 2 months before therapy. This is immediately before therapy. And then we start immunotherapy, and 6 weeks later, her disease has exploded like pouring gasoline on a fire. And what we found in our studies is that there are two types of alterations that predispose to hyperprogression. One is EGFR alterations, most of which just predispose to plain old resistance, but also MDM2 amplification, which is a high risk factor for immunotherapy. So important point, NGS can help define not only who to treat, but who not to treat. And that's probably just as important. Here's another example of the type of work that we did in the rare tumor clinic. This is a 49-year-old woman from Saudi Arabia. She came to see me in January 2016. She had a high-grade neuroendocrine cervical cancer. She'd had surgery, radiation, and chemotherapy. She was close to hospice. We had a problem. She did not have very long to live. She had a huge abdominal tumor, impending bowel obstruction, and pending kidney obstruction. And again, what would you do next? I think a lot of people would send her to hospice, not unreasonable. We did comprehensive genomic profiling, but we had a large problem, and that's that she didn't have long enough to live for us to get a tissue biopsy. So we did a blood biopsy, and we have experience with close to 6,000 patient samples. We got a sample of blood, and this is what we found in the sample of blood. She was chock full of mutations. The usual patient has 3 or 4 alterations max. She had over 20 alterations. So we guessed that she had a high tumor mutational burden. Remember, this is back in January 2016. And again, we treated her with nivolumab. This is an anti-PD-1 agent. And this is her tumor before, and this is her tumor after therapy. And she went back to Saudi Arabia after 3.5 years, but at that time she was still in complete remission. In the meantime, we looked at her tissue, and the tissue confirmed what we saw in the blood. She was full of mutations. Usually the patient has 4 mutations. She had a high mutational burden, mismatch repair gene defect, and so forth. So important point, cutting edge technologies like liquid biopsies are needed for complicated cancers. And now we can do blood-based tumor mutational burden and microsatellite status. But what if every patient with metastatic disease is different, like snowflakes, just like I mentioned before? And this is just like an example. These are 2 patients with breast cancer. They both have ERB2 amplification. They both should get a HER2 targeting agents, but look at the rest of their NGS. Each patient has a complicated array of alterations, and they're different from each other. So since when does it make sense to give these 2 patients the exact same therapeutic regimen? Yes, they have something in common, but the rest of their alterations are different. So we need to individualize, or that is at least what makes sense to me. And instead of using a consistent drug combination between patients, even in the presence of different molecular profiles, we should use the consistent strategy. So we set up a protocol called iPredict, and we set this up in 2015. And the idea was to give customized combinations based on NGS to each patient. And we've published the first version of this in Nature Medicine, April 2019. We have several other publications that are in the process of review, but this is what we found. First of all, matching patients to drugs is not a yes or no answer. The degree of matching is important. So if you have 10 alterations and you only match one of them, that's a very low matching score. And the likelihood is that you're not going to get a response. If you have 10 alterations, you have to match many of those alterations. If you have 1 alteration, much better chance that you're going to get a good response. And we found that patients with a high matching score had an objective response rate of 45% versus 16% for low matching score. And then when we looked at survival at 2 years, it was over 60% for patients with a high matching score versus about 20% for patients with a low matching score. Remember, every patient got got an individualized drug combination. And it's translated to better response rate, progression-free survival, and overall survival. And this is just an example of the type of matching we were doing. This is a 62-year-old man with a poorly differentiated carcinoma of unknown primary. He had a KRAS mutation, which was unusual KRAS, but it's pathogenic. So he got trametinib, which is a MEK inhibitor, and he had an ARID1 splice site alteration. ARID1A is a chromatin remodeling gene. It can predict response to several different drugs. One of them is PARP inhibitors. So he got olaparib. You can see what's happening to his tumor. Beautiful response. Therapy ongoing at 15 plus months. So this is an example of how we individualize therapy for each patient. I want to finish by talking about the Worldwide Innovative Network for Personalized Cancer Medicine. I am passionate about the global delivery of precision medicine. This is a nonprofit that is working in this regard, initially founded by John Mendelsohn, who is the president of MD Anderson. We've all looked at genomics. WIN Consortium has been concentrating on going beyond genomics, and our first studies have looked at transcriptomics. And the first study that we published was published in Nature Medicine. Very proud of this study for several reasons. First of all, it was international. Multiple countries were involved in this study, and that was a great experience. And then it was the first precision medicine trial that included not only genomics, but also transcriptomics for solid tumors. And we found that transcriptomics had an important role. We also have other new types of trials coming out. We published this one in Cell. It's a master observational trial, a registry trial with real world data that we hope will inform future decisions. And then just to finish off, I'll say we've concentrated a lot on the tumor. We need to concentrate on the host more because the host determines toxicity, response, immunity. This is a real patient. The question is, why did she get to 100 years old, be robust in your face? Is this good luck or genomics? And I think it is not good luck. This is her genomics. And then I want to finish with the one last thought. We are revolutionizing cancer medicine. But this is not about cancer medicine. I genuinely believe that precision medicine, which just means you understand what is wrong with a patient and you give them the right therapy for their disease, this will revolutionize all of cancer. And this is an example. It's not the only example, but it fascinates me. Bladder cancer has FGFR3 mutations. We now have drugs that we can target it. To me, it's fascinating. Children with achondroplastic dwarfism have the exact same mutation in the same gene and the same locus. And then the question is, could giving FGFR inhibitors, which are now FDA approved, to babies with achondroplasia, would it reverse their phenotype? And would there be other implications? And I don't know the answer, but it's been tried in mice with achondroplastic phenotype, and it works. And I want to thank the precision medicine team and the patients and all of you for listening and for the invitation. And I will stop there.
Ray, that was an amazing talk. And your passion poured through your talk. It just poured out and we witnessed it. And I'm just getting getting bombarded by messages of how lovely the talk is. And I will just read out what you just said. I don't care about many other tumors. I care about that patient's tumor. So I think we are all in awe of the N of one approach that you have. And truly, we have followed that. I have many questions in the chat, which I'm just going to read out. one of the questions was, when you look at tumors that evolve, do you also look at mouse avatars or mouse models to look at drug sensitivity testing? And what do you think of master regulator genes in figuring out what is the pathway?
So I think master regulator genes are, we don't know how to regulate them. And that's the problem. So we have a lot of work to do in the science. With the mouse models or any type of animal models, I think it's a really interesting concept. We've actually had only a small amount of experience with the models. And I will tell you what the experience is. This doesn't mean that the models aren't good, but they have practical problems. In the precision medicine field, because of the way the field works, you have to address the scientific problems, but you have to address the operational problems. And if you don't address the operational problems, you cannot make precision medicine work. And so we've had many patients that have had some of these animal models done. And inevitably, it just takes too long to get the results. These patients need results in 2 or 3 weeks. And the animal models have just taken too long. So we have not given them a good test yet. We don't have a good feel for whether they're predictive or not in our patients. That I'm not saying that they don't work or they do work. I'm saying that running a trial with the animal models presents some challenges because of the length of time it takes to get the results in many of these models. And the longer the time, first of all, you lose patients because a lot of these patients, you have 2 or 3 weeks and that's it. But the other thing is, if you don't lose patients, you've biased the trial because you've chosen patients that have indolent disease. So I think that these are interesting ways of looking at things, functional assays and so forth. We ourselves, and I don't know of anybody who has tested them well enough.
Thank you. Thank you. That is wonderful. I have another question here. What do you do when you see multiple potential driver alterations in a report? How do you choose therapy?
So we have a lot of experience with combinations, and we will do up to 3 or 4 drugs together to try and maximize the impact. And so we will look at the number of alterations. We have our matching score, the more that we hit at one time. And we published that in the iPredict paper in Nature Medicine. We've published it in the Molecular Tumor Board paper in Nature Communications. This was done on the auspices of a master clinical trial. There was a data safety monitoring board. We know how to do this safely. We start at lower doses and allow physicians to titrate the dose up. We didn't have any excess adverse events with this. And we have another paper that is in the end stages of review, follow-up on iPredict, same results in a very good journal, not accepted yet, but so it'll be more evidence that this can be done. Not what is typically done, but we did individualized combinations. And the reason that we did this individualized is because I want you to think about this. I'm a clinical trials. My expertise is clinical trials. But if there are 300 drugs on oncology, the number of 3 drug combinations is 4.5 million. We are never going to do all those clinical trials. We absolutely have to learn how to individualize therapy because 4.5 million clinical trials isn't happening. And it's much more than that, because just imagine doing those combinations in every histology. It's not happening. We need a new model, and that's what we try to develop with the PREDICT family of trials.
Great, thank you. I'm taking notes, Rick. So the next question is, do you believe in chemotherapy sensitivity testing and chemo drugs being covering 75% of cancer treatment? Do you see any role for combining chemosensitivity analysis and targeted therapy sensitivity analysis?
So I want to address an implication of that question. And one of the implications before I address the sensitivity is what people ask me is, so do you think chemotherapy is important? And my answer is absolutely yes. All chemotherapy is targeted. We didn't have the tools to define well what the targets were, but anybody who's an oncologist knows that chemotherapy works. It works just like any other therapy in a subset of patients. And every chemotherapy has a target. And, you know, beautiful examples are cisplatin or carboplatin, which are poor man's PARP inhibitor. They work almost the same. So I know you didn't ask this question, but because I'm asked it so much, I want to say that I think chemotherapy is critical, but we need a new age of chemotherapy where we actually test, does the patient have the target? And then the question is, what about chemotherapy sensitivity? How well does that work? And my answer is that we've had some experience with it. And I can tell you that anecdotally, some of that experience has been positive. But I think we need bigger studies to ascertain which assays are best and which are most predictive in the clinic.
Fantastic. I have another question with why TMB, even being holistic genomic marker, still fails to provide predictive clinical value in tumors like non-small cell lung cancer. It's a question from Ajay Patil.
Yeah, so tumor mutational burden for some reason has become a controversial marker. And I'm going to get clobbered, but I'm going to say this anyways. In my clinical experience, and also in our experience from the studies that we've written up from UCSD, tumor mutational burden is the single most important marker that I've ever seen. And if I could only have one test, I would test for tumor mutational burden. I think where tumor mutational burden becomes more controversial is at the lower levels. So the FDA approved it at 10 or more. And certainly between around 10 and 20 mutations per megabase, you get partial remissions in a small subset of patients. It's not irrelevant, but you don't see these spectacular complete remissions that you see in very high tumor mutational burden. And what we do is we usually give the immunotherapy in combinations. Now, the other question is, does tumor mutational burden work for every single type of cancer? And the answer is, in our experience, it does, especially at the higher levels and even in lung cancer. But I will pen that to saying, just like everything else, there's variability. So I think we have to equalize the questions. If we give chemotherapy to patients with lung cancer, does that work in everybody? Well, absolutely not. So why do we expect molecular markers to be perfect when we've never expected anything else to be perfect? So for me, that's the bottom line. But we've seen, some of the best responses that I've ever seen in my career as a physician have been in patients with high tumor mutational burden. Admittedly, this is the very highest level, but these patients don't have mismatch repair gene defect. They have high mutational burden, and they go from next stop hospice to being in remission for 3 or 4 years. As an oncologist, I've never seen this before, except in seminomas. That's the exception, testicular tumors. And I'm not talking about heme malignancies, but in solid tumors, we never saw this before. To me, based on my both clinical experience and research experience, I will reiterate, I think tumor mutational burden is the single most important marker. You could argue, definitely argue, if the cutoff of 10 is the right cutoff. Because it gives people the benefit of the doubt. But at the higher mutational burdens, I think the responses can be spectacular. And then I want to make one more comment. If, as there's a push in the United States to make the cutoff higher, I'm going to tell you what's going to happen. The people that are wealthy are going to get the drug. And even if the mutational burden is lower, and the people that are poorer won't get the drug anymore. And I do think that there's responses even between a 10 and the 20. So every time there's this push to roll back things, the end result is it doesn't roll it back completely. It just rolls it back for people that don't have financial security.
Thank you. Thank you, Ray. I'll take a last question. We're all out of time. I'll request you, Ray, to look at some of these questions and answer in the chat box as we are listening to Dr. Ganpati. One of the last questions is any role of precision application in head and neck cancer, India being a hub for oral cavity cancer. Have you had successes with precision application in oral cavity?
Absolutely. So we've looked at many different patients with different types of head and neck cancer. And by the way, head and neck cancer is not one type of cancer. You know, these are very different types of cancer. You know, just because the ovary sits next to the colon doesn't mean that they're the same cancer. And that's the true same in head and neck. We've sort of lumped them together, but these are very different types of tumors. And the answer is absolutely yes. Head and neck cancer is not an exception to the rule. We look at it in an individualized way, and we have a small stable of patients that have had beautiful responses. Not everybody, we're not perfect. We don't know how to do this perfectly, but we definitely see responses.
Fantastic. Thank you so much for a fabulous presentation and a lovely question and answer session. We'll come back to you in 5 minutes with the molecular tumor board that is going to be moderated by Dr. Nirmal Rao. Before that, Dr. Padmaja Ganpati is going to give us a very quick summary of Iylon and what we serve as.
Thank you so much, Massimo and Ray. And that was like ringside seats to the cancer opera, except that in the opera, you're supposed to cry. But here, as a layperson, I'm so excited that such advances are happening. And there is so much hope, and cancer is not the terminal disease anymore, more and more so. So that really brings us very nicely into our mission statement, because so much of what was said in these talks about precision, about that unique snowflake, is exactly what we are about here. Knowledge is power, like the iceberg that Ray showed us. You know, if only Titanic had seen the entire iceberg and not the tip of the iceberg. Iylon's mission is to go above and beyond to empower the cancer patients with state-of-the-art personalized treatment, and which is the key, as we've heard over and over. Okay, so I already went through the mission statement, and we do stand with the patient and the physician, importantly, because the physician is the one who's going to implement the recommendations. And our mission is just to beat cancer, simple as that. Next slide. And our vision is to bring the international expert advice to the fingertips. So we have developed a mobile app, so the patient, the physician, and also the consultant can utilize this app on their phone, be it Android or iOS, and enter their data, and we are able to get this as quickly as possible to the patient. And we have experts in precision oncology, genomic medicine, molecular biology, molecular pathology, oncology, you name it, and this list is only growing. Next slide, please. So I would like to go to our products. We currently offer 3 products. The next slide will have our first one, which is our flagship product, the International Precision Oncology Consultation, where our oncology expert will review both the clinical and the genomic information and recommend individualized treatment plan. But as the next slide shows, our second product is for people who do not yet have genomic testing. Now, we will be partnering for that, but we will come to that probably in another meeting when we have it all set up. But if for people with no genomic testing, we would still like to offer expert opinions so that they can start their treatment while they're waiting for genomic testing. Probably, like Ray said, some people have 2 weeks, so we don't really want to wait for them. And we have yet another product which we brought up recently, which is a virtual consult, because a lot of people really want to sit with the doctor, the expert, and their physicians have questions. So we have introduced an international virtual oncology consultation where, thanks to Zoom, we can have a Zoom consult for an hour and really answer questions in a virtually real world, in real time. We are totally committed to bringing the right treatment to the right patient. And like Ray said, everyone is a snowflake, but not the connotation we go with these days, but in terms of the diversity. And we are hoping to deliver exceptional service with empathy, sensitivity, and speed, because all things said and done, these are patients, these are mothers, fathers, wives, children. And we want to provide them the personalized care that every single person deserves in the world. Thank you.
Thank you, Padmija. That was wonderful introduction to Iylon. I would just add here what Mani had said earlier. One of our biggest mottos, in addition to providing patient care, we intend to propagate research and build upon our own knowledge base to elevate the level of cancer treatment and reach out globally to cancer patients.